The topic for discussion today is diarrhea. Diarrhea is actually defined as passage of stools which is more than normal. That is, abnormal amount of passage of stools is called as diarrhea. In medical definition, it is usually defined as passage of more than 200 grams of stool per day. Patients usually with diarrhea have this urgency for defecation, okay, and they'll have fecal incontinence also. There are actually two different types of diarrheas, and most grossly they're actually defined as acute diarrhea and chronic diarrhea. Chronic diarrhea or else relapsing type of diarrhea. Now coming to acute diarrhea, acute diarrhea is most commonly seen in younger children, school-going children, infants and adolescents. People who are in adolescent age who actually have this habit of eating street food, junk food, etc. And usually the most common cause of this acute kind of diarrhea is about fecal-oral contamination. This can be because of any unsafe drinking water, any food contamination or improper washing. The patients usually do not wash their hands properly and they eat. So the contaminants that are present on the hand usually go into the stomach and this can cause diarrhea. And other causes include viruses, certain parasites and even stress, that is psychological or physiological stress is also known to induce this acute type of diarrhea. Now coming to this fecal-oral disease transmission, usually it can be seen in areas where there is sanitation is not proper, improper hygiene areas, where people usually have this habit of defecating in outside, instead of using proper sanitations or using bathrooms, these people usually go and defecate outside. So what happens is they don't wash their hands properly, and the flies or certain vectors such as flies, house flies, etc. These actually carry the infection from these areas onto the food, and improperly covered food, improperly washed hands and soil. And the water that is been any contaminated water between drinking water and sewage water, the pipelines are not properly maintained, there can be contamination of this drinking water with the adjacent sewage water. All these factors actually will cause this fecal-oral disease transmission, and this is one of the primary cause for acute diarrhea. Now coming to other types of diarrhea such as infective diarrhea, usually this is a short-term one, and if it actually exceeds more than 10 days, then it is less likely of infectious origin. So generally infectious origin diarrhea extends only in a short period of time. It is very acute and limits itself for a shorter period of time. If at all this type of diarrhea exceeds for more than 10 days, then we can actually think it is not of infective origin. Now organisms such as Bacillus cereus, Staphylococcus aureus, Vibrio cholera, they have these exotoxins which they release. So these diarrheas are usually associated with other symptoms such as nausea and vomiting. And this condition is also called as secretory diarrhea, where watery diarrhea without blood or fecal leukocytes are present on fecal culture. Management of this acute diarrhea is usually by antibiotics, and also cytotoxic drugs can be used, NSAIDs, proton pump inhibitors can be used, and fluid replacement is a primary treatment for them, because there will be electrolyte and water imbalance is usually seen in case of diarrhea, because there is excessive loss of electrolytes, excessive loss of fluid from the body in the form of stools, resulting in electrolyte fluid imbalance. Hence fluid replacement in these conditions is very, very important, especially in case of cholera. Patients has to be treated with ORS solutions, and they also have to be treated with lots of fluids with slight intake of salt and sugar. The ORS mixture also has to be given to them. Now coming to antimicrobial associated diarrhea, the common complication of this antimicrobial therapy is based on most commonly is this broad spectrum antibiotics. These have a negative effect on the microbial flora of the gut, which actually are helpful for the body. Whenever this microbial flora, because of this antimicrobial therapy, what it does is it will cause death of this microbial flora, and this will result in diarrhea, irritation of the gut resulting in diarrhea. Usually seen in elderly patients, and also the most common organism for this antibiotic associated diarrhea is Clostridium difficile. There will be evidence of colitis in these conditions. Clostridium perfringens also is seen, but it is a rarer condition. Now coming to diagnosis. Diagnosis is by identifying Clostridium difficile. Clostridium difficile is the primary condition, the primary organism that is been associated with this antimicrobial associated diarrhea. Now coming to the management, usually the first line of treatment for this antibiotic associated, antimicrobial associated diarrhea is management, that is with metronidazole and vancomycin. These are drugs of choice in this case. Now coming to chronic or relapsing diarrhea. Chronic diarrhea or relapsing diarrhea, the commonest condition, the commonest cause for this is irritable bowel syndrome. The symptoms for this are there will be increased frequency of defecation, watery, loose stools can be seen, pellety stools can also be seen in these cases, and it usually occurs in the morning time and rarely occurs during night time. Usually it is more severe before and after breakfast. Sometimes patients will have this constipated feeling. So there will be periods of diarrhea and which is followed by periods of constipation, which is again been changing. I mean, there's periods of diarrhea and constipation take roles in case of this chronic or relapsing diarrhea. Usually the most common or pathognomic feature of this condition is it is usually severe before or after breakfast. That is, it is been associated with food intake conditions also, the timings of food also. The stool often contains mucus and 24-hour stool volume is less than 200 grams. Remember, the diarrhea which we are talking about is the defecation will be usually greater than 200 grams. But then in this condition, that is in case of relapsing or chronic diarrhea, especially in case of irritable bowel syndrome, the stool volume, 24-hour stool volume will be less than 200 grams. There are different types of chronic diarrhea based upon the disease of which part is being affected. If at all the colonic part is affected, then it's called as colonic diarrhea. If it is because of malabsorption, it is called malabsorption induced chronic diarrhea, and it is present within the small bowel or because of any pathology within the small bowel, then it is called as small bowel chronic diarrhea associated with small bowel or chronic diarrhea within the small bowel. Now coming to colonic diarrhea. Normally this colonic diarrhea contains blood and mucus. Lower abdominal pain and cramp is one of the commonest conditions in case of colonic diarrhea. There are multiple causes, it is of varied etiology, and certain causes include microscopic colitis, any neoplasms, if there are any ischemia present, in case of any inflammatory bowel disease or irritable bowel syndrome also we can see colonic diarrhea. These are some of the causes of colonic diarrhea. Coming to investigations. Apart from the stool volume, the per day stool volume, we have other investigations which include fecal calprotectin. Fecal calprotectin is assay can be done, and ileocolonoscopy with biopsies can be done. Colonoscopy is one of the gold standard tests to check for any pathologies within the colon, and colonoscopic biopsy, ileocolonoscopic biopsy also will help us to come to a proper diagnosis, because biopsy will be another gold standard for knowing which type of pathology is associated with the colon. Now coming to diarrhea due to malabsorption. This is also one of the commonest cause because of malabsorption, and the causes for this diarrhea due to malabsorption include any steatorrhea. Steatorrhea is nothing but fat within the stools, weight loss conditions, undigested food in the stool, and nutritional disturbances. These are the features that have been associated with diarrhea due to malabsorption. I'll repeat the features, which include steatorrhea. The patient will usually have malabsorption. There will be food, undigested food within the stools, and also any nutritional disturbances can also be seen. Causes are again of various causes, and most important causes can be grossly divided into pancreatic causes and enteropathic causes. The pancreatic causes include chronic pancreatitis, any carcinoma of pancreas, and cystic fibrosis. And the enteropathic causes include celiac disease, any lymphoma, tropical sprue, or lymphangiectasia also can be some of the causes of this diarrhea due to malabsorption. Now coming to investigations. Most common investigations include ultrasound, CT, ERCP, small bowel biopsy, and barium follow-through. This barium follow-through, what happens is whenever we take a barium meal, if there is any constriction of this, any ulcer, we can actually visualize any deficiency. The barium flow will not be proper, will not be consistent if there is any pathology. If there is either any obstruction or if there is any ulcer also, we can see, or if there is any leakage also, we can see this through this barium follow-through. And ultrasound is again a real-time imaging where we can actually see through the endoscopic probe or through the ultrasound probe, we can actually see what kind of pathology is present within the lumen, of the colon, or even in the any pathology within the pancreas, or if there is any ulcer or any kind of pathology can be visually visualized with help of ultrasound. And then and endoscopy also will actually help us with the clear-cut vision. Ultrasound will help us with any cystic or any solid lesions can be actually be seen with the help of ultrasound. And small bowel biopsies, obviously histopathological will help us with histopathological diagnosis, and it is usually the gold standard for the for any diagnosis of this diarrhea due to malabsorption. That means we can know which area is actually involved in this. Now coming to small bowel diarrhea, usually this kind of diarrhea is being seen associated with any pathology within the small bowel. It has a pathognomic features such as large volume, watery stools is seen. Patients exhibit abdominal bloating and cramps can also be seen in these cases, and there will be pain in the mid-abdominal region. Patients usually complain of pain with the mid-abdominal region in the small bowel diarrhea. Large volume watery stools, pain in the mid-abdominal region, patients will have abdominal bloating and cramps are the clinical features of this small bowel diarrhea, and usually the causes includes VIPoma and drug-induced such as we have NSAIDs, aminosalicylates also as some of the drugs with causes of this small bowel diarrhea. Now coming to investigations. All investigations, obviously stool volume, this will be a standard test. We have a hormone profile and barium flow will also help us in investigating this case of small bowel diarrhea. Now coming to amoebiasis. Amoebiasis is, as we all know, it is caused by a parasite which is nothing but Entamoeba histolytica. It usually spreads through cysts between the humans. This cysts are nothing but trophozoite cysts, and it is also called as amoebic dysentery, and if liver is also involved then it is called as liver abscess. Now coming to the pathology, how it actually, the flow chart, here is a flow chart which shows us on ingestion of a contaminated water and fluid and water, what happens is the mature cyst will actually enter into the your gut. And when it enters there will be something called as invasive infection, which will be initially what happens is there will be excision, that is this the one trophozoite within the nuclei will emerge, divide, and then it will enter into the bloodstream. These trophozoites then they migrate into the large intestine. After they migrate into the large intestine, they multiply with the process called as binary fusion. Binary fission. With the help of binary fission, what happens? These trophozoites will be multiplying in number. After they multiply, they enter into two different phases. So now we have the trophozoites in the large intestine which will invade the intestinal mucosa, and then it will cause invasive infection. So one stream is within the large intestine. Once the trophozoites get divided, this will enter into the intestinal mucosa, and from there this will have an invasive infection through the bloodstream, infecting sites such as liver, brain and lungs. Second step is that it will actually undergo encystation. After this encystation, it will become an immature cyst, and this will become, it will actually divide within it, and this will form a quadrinucleate cyst. Quadrinucleate cyst is nothing but it will have 4 nuclear parts within it, and then this will cause a non-invasive infection which will actually invade the intestinal mucosa, results in invasive infection, and that not entering into the intestinal mucosa, then it will cause this non-invasive infection where the cyst will exist in the stool. Once this stool is being passed out, these trophozoites within the stool will again act as an infectious material. That is, when this being contaminated with the local with any water or any local bodies and improperly washed hands, etc., and when this infection can be carried from this person to another person with the help of this quadrinucleate cyst, which is called as non-invasive cyst or non-invasive infection, which occurs outside the body. So this non-invasive infection will actually help in causing cross-infection, that is infection from one person to another person. So this is the pathology of amoebiasis, how it has been invading within the body and also invading other people or other from one host to another host. Now coming to the clinical features. Clinical features, as we actually discussed, amoebiasis can be of two types. One is intestinal amoebiasis, that is amoebic dysentery, or it can also lead to liver abscess. Now let us discuss about amoebic dysentery. Amoebic dysentery, most people are usually asymptomatic in this phase. It actually has an incubation period of 2 weeks to many years. In the chronic course, what happens? Patient will have abdominal pain. 2 or more unformed stools per day can be seen. It can have 2 or more unformed stools per day. Offensive diarrhea alternating with constipation, which will have mucus and blood in the stools, can be seen. Abdominal pain is usually seen in the right lower quadrant, which will actually simulate appendicitis. So this amoebiasis pain resembles appendicitis, acute appendicitis, as because of the abdominal pain in the lower right quadrant of the abdomen. In older people, what happens is there will be a dysenteric presentation with the passage of stools. Coming to amoebic liver abscess, it is usually found in the right hepatic lobe and it may not be associated with diarrhea. The early symptoms of this amoebic liver abscess is there will be local discomfort, there can be malaise also, and late symptoms include there will be swinging temperature. Temperature can be raised in some cases and it can fall down and again can rise. So there will be swinging type of temperature in case of amoebic liver abscess. Patient will have sweating. However, there will be no marked systemic symptoms can be seen. However, there will be a characteristic enlarged tender liver, that is nothing but hepatomegaly. Patient will have cough and this cough will have actually, and it also will have pain in the right shoulder. A pathognomic or characteristic feature of amoebic dysentery of liver abscess, amoebic liver abscess includes enlarged and tender liver with cough and pain in the right shoulder. Remember this. There will be a large abscess which may penetrate through the diaphragm and it can rupture into the lung also. Now coming to the investigations. Microscopic investigations, examination for stool for mobile trophocytes can be done. That we will have a quadrinucleate trophocytes in those cases. Sigmoidoscopy, that is endoscopy, will actually show us a typical flask-shaped ulcers. Remember, they will have a typical flask-shaped ulcers. This is maybe scraped and they can be examined for entamoeba histolytica. Amoebic abscesses, they will actually show neutrophil leukocytosis and they will be raised right hemidiaphragm on the X-ray chest. This is because of hepatosplenomegaly. Okay, this is because patients usually present with tender and enlarged liver. In these cases, what happened? There will be raised diaphragm on the right side. That is right hemidiaphragm raise can be seen on a chest X-ray. Ultrasonic scanning is useful in these cases and aspirated pus from the amoebic abscess is characteristic chocolate brown or anchovy sauce appearance. Patients, this the pus that has been taken from the liver abscess, aspirated from the liver abscess, will have a characteristic chocolate brown or anchovy sauce appearance. Normally, they have serum antibodies by immunofluorescence and DNA detection with PCR will also be helpful. Coming to the management, oral metronidazole is the first line of treatment, especially 800 mg thrice daily for 5 to 10 days. And long-acting nitroimidazoles like ornidazole, tinidazole can be given, that is 2 grams per day for 3 days can be given. To eliminate this luminal cyst, we have diloxanate furoate or paramomycin, which is 500 mg thrice daily for 10 days can be given in these cases. However, remember, amoebiasis can be prevented. Prevention is always better than cure. So, by properly maintaining the sanitation, by washing the hands properly before food and after, attending urinals, and personal precautions like drinking pure water, filtered and safe drinking water, eating washed vegetables and fruits, washing hands after using washrooms and before every meal will be helpful in preventing this amoebiasis. Now, coming to malabsorption. Malabsorption is a condition where usually malabsorption, the name itself shows that there is defective in absorption of the food. So usually less than 5% of carbohydrates, fats and proteins is excreted in stools. This is the normal condition where there will be all these carbohydrates, fats and proteins will fall under less than 5%. Anything greater than this is nothing but malabsorption. Diarrhea and weight loss in patients with usually normal diet may be due to malabsorption. There can be varied symptoms and in severity also can be varied. Bulky, pale, offensive with float in the toilet, that is nothing but steatorrhea. That is this usually contains more amount of fat. Steatorrhea is nothing but fat in the stools. This is nothing but fat malabsorption. The condition can be actually assessed by there will be bulky and pale, offensive with float in the toilet is seen in case of fat malabsorption. Abdominal distension, cramps, weight loss and undigested food in stools can also be seen. Patients usually have malaise, lethargy, vitamin and trace element deficiency might be seen in these cases. Now coming to etiology. Etiology is of different types. It can be because of intraluminal maldigestion or it can be mucosal malabsorption. Coming to intraluminal maldigestion, that is some problem with the digestion. That is either can be secretion of these acids or the digestive process itself can be defective in this case of intraluminal maldigestion. This will include, it can be due to deficiency of pancreatic and bile enzymes. When pancreatic and bile enzymes are not produced properly or have not been are not functioning properly, then it can lead to malabsorption. This can lead to inadequate hydrolysis. It can lead to solubilization of nutrients, and thus it can lead to fat and protein malabsorption. Now coming to mucosal malabsorption, it is usually because of any small bowel resection or damage to the small intestinal lining epithelium. Most commonly there will be decreased area of absorption in this mucosal malabsorption because either there has been resection of this mucosa or there will be defect in the intestinal lining epithelium. There is something called post-mucosal lymphatic obstruction. In this post-mucosal lymphatic obstruction, what happens is, usually in these cases, there will be diminished uptake and transport of the absorbed lipids into the lymphatics. Now the lipids which have been digested, they have to be taken up and they have to be sent through or transported through the lymphatics. Now this process is being diminished or it is being reduced in action. There will be pressure inside leading to escape into the intestinal lumen, and thus it can lead to protein loss in enteropathy. Now coming to the diagnosis. Diagnosis of this malabsorption can be based on complete blood picture where we can see anemia because there will be malabsorption of iron. Malabsorption can from the food substances, hence iron deficiency can be most commonly seen. So in the peripheral blood smear, what happens? We can see microcytic hypochromic type of red blood cells which indicates a microcytic hypochromic anemia. Either can be because of B12 deficiency or because of deficiency of folic acid, or it can be because of deficiency of iron. In case of iron deficiency, we see microcytic hypochromic, and in case of vitamin B12 deficiency or folate deficiency, we see macrocytic anemia or macrocytic RPCs. Next is there can be increased prothrombin time. This is because vitamin K deficiency. Usually there will be malabsorption, hence it can also result in vitamin K deficiency, which is nothing but it is usually manifested as increased prothrombin time. Now coming to other deficiencies, it includes hypocalcemia. Vitamin D deficiency can also be seen in these cases associated with hypomagnesemia. Hypoalbuminemia, zinc and phosphate deficiency can also be seen. These are all the serological tests that can be done in plasma or blood investigations or biochemical investigations which shows us these various deficiencies. So this can give us a clue that there is malabsorption. This is happening. So these are the various kinds of gut diseases, and understanding these diseases will help us in especially the malabsorption, so that if there is malabsorption, further diseases can also happen. So when malabsorption has been properly diagnosed and treated, then any associated or further diseases or its consequences can be identified or controlled. Thank you.